So it's such a great honour to be here in beautiful Boston today for the Boston Lymphatic Symposium. My name is Robbie Blackwell and I work as part of the ALERT program in Sydney, Australia, where for the past 7 years we've been using ICG Lymphography within our multidisciplinary outpatient clinic as a diagnostic assessment tool. Throughout this time, our use of ICG at Macquarie has taken us on a journey of discovery regarding how the lymphatic system compensates in the case of damage, dysfunction, or deficiency of the lymphatic system. Today, on behalf of researchers and clinicians at Macquarie University, I have the great privilege of sharing our research and its capacity to inform both our understanding of lymphatic compensation, but also the conservative recommendations that we make to our patients living with lymphedema and other forms of chronic edema. So nothing to declare. Before we begin, I'd like to acknowledge my colleagues and co-authors of the paper that informs much of the content of today's presentation. I'd particularly like to acknowledge the work of Associate Professor Hiruswamy, whose innovation and dedication to this specific field of lymphatic research really is quite amazing. So firstly, today I'm going to describe our use of ICG lymphography as a diagnostic tool in our outpatient clinic and how it can help us to discriminate between normal and impaired lymphatic drainage. Secondly, I will outline our ICG research findings regarding the where and how of lymphatic drainage in people living with lymphedema. By where, I refer to the drainage region, or where does fluid in a lymphodematous limb drain to in order to find access to the deeper lymphatic trunks and ducts on its way back to blood circulation. And by how, I refer to how the fluid travels through the limb in order to get to that drainage region. We refer to the how as the drainage pattern. Finally, we will look at the application of ICG lymphography in guiding clinical assessment and conservative management of patients presenting to our clinic with edema symptoms. So I'd like to start with some background information on ICG lymphography for those in the room that may not be familiar with this lymphatic imaging technique. ICG is a dye test that allows us to image a person's superficial lymphatic drainage in real time. It makes evident the pathophysiological adaptations of the lymphatic drainage system, and it's helping to shape a contemporary understanding of lymphatic compensation in order to maintain tissue fluid homeostasis in a limb. ICG uses 4 standardised injection sites around the hand and wrist, or foot and ankle, depending on which part of the body we're investigating, as we have 4 main pathways in the arm and the leg, and so making these 4 injections gives us the best chance of seeing presence of or absence of these pathways. The injection sites associated with our protocol are pictured on the slide here. And the dye, when injected into the interstitium, binds with protein, and as the protein is taken up by the lymphatic system using a near-infrared light and camera, as you can see Professor Hiruswamy holding in this picture, we're able to see the structure of the lymphatics as dye passes through the vessels. In relation to lymphedema centres around the world, ICG is most commonly used as a tool for surgical planning. It can help to determine a patient's eligibility for lymphatic microsurgical techniques and is used as a tool to evaluate outcomes of lymphatic surgeries. So at ALERT, like in the Boston Lymphatic Center, we're also using we've developed a multidisciplinary diagnostic clinic whereby we use ICG as a diagnostic tool where the imaging patterns are used to differentiate between normal lymphatic drainage and impaired or compensatory lymphatic drainage. Additionally, ICG imaging is used to devise personalised conservative management plans for our lymphedema patients to improve their outcomes and their knowledge of this condition. So this diagram shows the tissue space in which the superficial and deep lymphatics are located. ICG allows us vision of about 1 to 2 centimetres beneath the skin, and this allows us to objectively assess the structure of the superficial lymphatic system, which lies above the deep fascia. It's usually some sort of impairment or assault on the superficial lymphatic vessels or lymph nodes that causes lymphedema. Before we look at the drainage pattern observed in people with lymphedema or impaired lymphatics, let's begin with understanding what normal superficial lymphatic drainage looks like. In limbs with normally functioning lymphatics, we observe fluid transport via superficial lymphatic collector vessels, and this takes us back to our normal lymphatic anatomy. I'm just going to play the clip here. So in normal conditions, what we see are the collector vessels, and they're observed as linear vessels. And in this non-impaired arm, we can see collector vessels draining proximally towards the ipsilateral axillary lymph node drainage region. It's interesting to note that we often see structurally intact or linear collector vessels in people with chronic edemas, particularly in the lower limb. We then consider the cause of the edema to be a high output failure, where fluid overload within the tissue is the predominant issue, rather than an impairment of the lymphatic system or the transport system itself. This has implications on the sorts of conservative management recommendations we make, but we do almost exclusively see this in the lower limbs, as upper limb edema is almost always secondary to damage of the lymphatics from treatment for cancers. In the case of lymphedema, a different pattern of drainage known as dermal backflow is observed, whereby the initial lymphatics, as you can see here, or the lymph capillaries, are recruited for transportation of lymph fluid. Now, in this footage, what we're seeing is a collector vessel. So we're seeing a linear vessel, but at this point here, the movement in that vessel stalls, indicating some sort of damage or obstruction to that collector vessel. And then what we're seeing here is fluid refluxing into the dermal capillaries, or those initial lymphatics. These capillaries are an interconnected network, and fluid will move directionally, albeit slowly, in this pattern of dermal backflow toward the drainage region. And the drainage region is a little bit like an outlet valve in the limb, or like the plug hole in a bath. The presence of dermal backflow in a limb is an imaging criteria for the diagnosis of lymphedema and differentiates lymphedema from other forms of chronic edema. We don't see dermal backflow in patients that have no lymphatic impairment. I'm just going to play a small segment of a clip developed for our online education learning modules. And this is a nice visual summary of what we're observing at a physiological level with ICG lymphography. See if it works.
As expected in normal lymphatic drainage conditions, we see the uptake and transit of dye within lymphatic collector vessels. In this clip, collector vessels in the arm are transporting fluid that originates in the superficial tissue of the arm toward lymph nodes in the ipsilateral axilla region. In the case of damage, dysfunction, or deficiency of lymphatic collector vessels, the body begins to compensate for the decreased capacity of collector vessels to transport fluid. In this animation, we see that this collector vessel is no longer a viable conduit for fluid transport as a result of treatment for cancer. We see fluid moving through the compensatory drainage pattern known as dermal backflow.
So an analogy we often use with our patients to explain the difference between normal and impaired or compensatory drainage is that lymphatic collector vessels are like highways or interstates, I think you call them here in America. And dermal backflow is a little bit like back roads. So if the interstate is obstructed due to an accident, fluid will take a detour. And and the D2 is via the lymphatic capillaries in the skin to bypass that accident or obstruction. If another nearby highway is available, fluid will detour onto that highway. If not, the fluid might stay on the back roads all the way to the destination or to that lymph node region. The back roads are narrow, windy, congested and slow, and therefore without interventions, the capacity for our lymphatics to maintain tissue fluid homeostasis is a little diminished. Compensatory drainage is the term that we use at ALERT to describe the physiological adaptations made by the lymphatic system to maintain drainage in the case of lymphatic impairment. So after a patient has their ICG investigation with us, we aim to provide them with two important pieces of information, both to the patient and to their treating therapist, to guide their ongoing conservative care. The first is the drainage region. And for this patient, you can see the chart that's up in the right-hand side of this slide. This patient, the drainage region, is the gluteal region, and we're going to have a better look at the different drainage regions for the leg on a subsequent slide. The second thing we aim to provide is the drainage pattern, or how the fluid is getting to that drainage region. So for this patient, you can see the predominant pattern is via dermal backflow. There are a number of segmental collector vessels marked in blue on that chart, but that area indicated by the red shaded area is the dermal backflow, and then the arrows indicate the direction that the fluid is moving through those dermal capillaries in order to make its way to the drainage region. We also provide a manual lymphatic drainage sequence to our patients, outlining techniques and sequences that are tailored to their individualised drainage patterns. And finally, we provide one-to-one education to discuss personalised conservative management recommendations based on the objective findings of the ICG lymphography. So in the early phases of using ICG at ALERT, we saw the significant impact that having ICG can have on the lives of our patients. We were able to personalise plans for our patients, and give them an understanding of what was going on in their body. And as great as this was, we felt really aware of the lack of access for most people to having ICG lymphography in this sort of a context. After performing many hundreds of ICGs, we commenced with analysis of our data regarding the most common drainage regions and drainage patterns that we were seeing in this clinic. We began to recognise the potential impact of this research on the wider population of people living with lymphedema. And we're really pleased to be able to share our published data with you today. This evidence now forms the basis of our education programs for students that choose to do their lymphedema accreditation or certification courses with Macquarie University. So we're now going to move to objective 2 and start to have a look at some of these common drainage regions and patterns that we see in people with lymphedema. So Louise has already shared with you some of the data regarding the arm and pointed out that one of the most interesting findings that we had doing this research was that even in the case of axillary lymph node dissection, 3/4 of our patients continue draining to that ipsilateral axillary region. It's an even higher percentage. It's something like 91 or 92% in patients that have early stage lymphedema, or where the onset of the lymphedema is relatively recent. The other interesting finding for the arm is that we just haven't seen a single patient draining from the arm to the inguinal region. So that makes our MLD sessions a whole lot more efficient. Moving to look at the leg. So in contrast to the arm, where the cause of lymphedema is almost exclusively cancer, as we all know, lower limb lymphedema can have multiple causes. So for this reason, the drainage of the lower limb has been divided into 2 subcategories. We have our secondary cancer-related lymphedemas and our other lymphedemas, which includes both primary lymphedemas of the lower limb and secondary non-cancer-related lymphedema of the lower limb. The regions listed on this slide, so ipsilateral inguinal, popliteal, gluteal, contralateral inguinal, posterior thigh, upper lateral thigh, lower abdominal, and axilla are the main drainage regions that we see in patients with lymphedema. So let's start. This slide is actually looking at our secondary cancer-related lower limb lymphedemas. The drainage regions of 167 legs of 132 individuals were assessed with ICG. So this subset of patients demonstrated a 61% chance of drainage to the ipsilateral inguinal. And we consider this to be the original, maintaining drainage to the original drainage region. We had 29% demonstrating drainage, that's supplementary drainage that some of our patients have and some of our patients don't have in normal conditions. So we consider that to be original, but supplementary or a normal anatomical variation. In cancer-related lymphedema of the lower limb, we observed that often patients drain to more than one drainage region. And they often drained to both original and compensatory regions. So you can see there, we've got a fairly high chance of drainage to that gluteal drainage region that we saw on the previous slide. The contralateral inguinal drainage region was also fairly commonly observed in this subgroup of patients. So when we're inferring the most likely drainage regions in this subset of patients, it's worth considering that dermal backflow may extend beyond that original drainage region towards one of those compensatory regions. A very small number of patients in this subgroup demonstrated drainage from the leg to the ipsilateral axilla drainage region. We observed this exclusively in patients with gynecological or patients that had had treatment for some form of gynecological cancer. And in fact, this was the only subgroup of arm or leg lymphedema in which we observed fluid crossing the transverse watershed in that pattern of dermal backflow. So moving now to have a look at lower limb lymphedema in patients with a cause other than cancer. So in this group, the 227 legs of 180 individuals were assessed with ICG Lymphography. In this subgroup, we saw a much higher likelihood of drainage being maintained to the original drainage regions than in cancer-related leg lymphedema. And that stands to reason that these patients are less likely to have had an inguinal lymph node dissection than somebody with cancer-related lymphedema. These patients were less likely to have additional drainage to those compensatory drainage regions. And in this group, we observed a higher likelihood we observed a higher likelihood of drainage to those compensatory regions in patients with the more severe progressed cases of lymphedema. So sorry about this very busy slide, but just summarising ICG research pertaining to leg drainage regions. Firstly, we subcategorise our leg lymphedema patients into cancer-related and other. Patients with leg lymphedema from a cause other than cancer are very likely to maintain drainage to that original region at about 86%. Patients with secondary cancer-related leg lymphedema are less likely to maintain drainage to the original region, but it's still at about 60%. So we do need to still consider that they may well be draining to that original region. But these patients also have a higher likelihood of draining to more than one region. And so when treating these patients, both original and compensatory drainage regions should be targeted, particularly the contralateral inguinal and gluteal regions. A higher severity of lymphedema in either category can strongly indicate drainage to those compensatory regions outside of the limb. and drainage from the legs to the axilla has only been observed in a small number of patients with gynecological cancer-related leg lymphedema. Okay, let's move on now and look at some of the attributes of dermal backflow, or the drainage pattern, or how the fluid moves to those regions. Dermal backflow, or bridging dermal backflow, as you may sometimes hear it referred to as, is by far the most commonly observed compensatory drainage pattern seen in patients with lymphatic impairment. This clip describes one of our key findings regarding dermal backflow movement patterns.
Fluid movement is directional, albeit often slow, toward the drainage region. Lymph cannot be manipulated by the therapist in directions that oppose the body's naturally occurring compensations. In other words, lymph travelling in dermal lymphatics will not go where it does not want to go.
So where does it go? This infographic has been developed to depict the different dermal backflow patterns. This clip also portrays the systematic approach of lymphatic compensation, whereby fluid will continue to spread through dermal capillaries to find the most efficient option. How efficiently the body is able to compensate seems to depend on the extent of damage to the lymphatic vessels. Okay, so I'm just going to talk through this. I'm hoping my timings match up with the images. So in the early stages, we see fluid moving through a collector vessel, which becomes blocked and gives rise to an area of dermal backflow that in this example bridges a short distance to a nearby functional collector vessel. In the case that there are no alternative functional collector vessels in the limb, fluid will travel through a more widespread network of dermal capillaries toward the original drainage region, which in this example is the ipsilateral axilla. And as we've seen, approximately 76% of patients with arm lymphedema will maintain drainage to this region, albeit with a slower transit time. In more severe cases where the axillary drainage region has been completely obstructed, we observe dermal backflow detouring to completely bypass the axilla. In this example, at the midline, dye stabilizes in dermal backflow as fluid drops into the parasternal drainage region, and this is something we commonly see. In some people, we observe a transition at the midline from a dermal backflow pattern to functional collector vessels in the adjacent unimpaired quadrant, and fluid drains to the intact contralateral axillary lymph node region on its way back to blood circulation. Just seeing images in a leg now to describe another pattern that we often see. So in this final example, we see fluid moving through dermal capillaries to a region with no known underlying lymph nodes. This is the gluteal region that we've seen a couple of times. So fluid is thought to drain to deep subfascial collector vessels via a perforating vessel that runs alongside the vascular bundle. The commonly observed gluteal drainage region is an example of this type of deep entry point. And this explains why on our drainage regions for the leg diagram, why those areas are not all associated with lymph node basins. So some of those points are these deep entry points. Let's move on now to describe some of the clinical implications of our ICG lymphography research. So this should hopefully be a nice familiar framework for everybody here. It's the best practice model for conservative management of lymphedema. And in some way, this framework guides our conversations, our recommendations, our education with our patients. Much of what we all do in our day-to-day roles is guided by this framework. ICG lymphography provides a more thorough understanding of what is happening at a physiological level in our patients' limbs, whether they've had an ICG or not. Provides an insight into how our conservative management strategies can help to facilitate fluid movement to improve a patient's outcomes. In some way, ICG lymphography research can guide each component of this framework. Let's start with manual lymphatic drainage massage. So understanding where and how a patient is draining informs which MLD techniques and which MLD sequences will be most effective in facilitating fluid movement. As we saw in that clip before, we have found that we can't move dermal backflow in directions that it doesn't want to go. So it will move purposefully and directionally towards one of those drainage regions. It's a pressure-based system, so it kind of moves where it can move based on where the pressure is lower and where that outlet valve is in the body, so that fluid accumulating in the superficial interstitium can find its way to the deeper drainage structures. So we've observed that pressure of massage is really important in helping to facilitate fluid movement. And Louise spoke a little bit about firm pressures, needing firmer pressures over areas of congestion. So gentle massage techniques for lymphatic collector vessel drainage, where there are collector vessels present, a light massage technique really is enough. And actually Hero will draw, Fiona or myself will draw where we're seeing those linear channels. We'll use a green Sharpie pen and we draw that on the patient's skin to indicate what's going on beneath the skin. And the pressure of the pen is enough to see the bolus of dye moving through the collector vessel. It's really quite amazing. And I do wonder whether in some respects that may be where our light effleurage massage came from, but where people have intact collector vessels, they don't really need massage because their collectors are quite functional. However, where dermal backflow is present in limb, we've observed slow, firm massage technique applied in the direction of the suspected drainage region is the most effective at facilitating fluid movement. And in this afternoon's workshop, I'll be presenting some basic principles on how to infer where dermal backflow is likely to be present or absent in an edematous limb. So stay tuned. This footage demonstrates quite nicely how fluid movement through dermal backflow can be helped with that slow, firm massage technique. It's only fairly short. I took this last week. And you can see right there, look at that fluid moving. You can just see a linear vessel pop out of that dermal backflow. It's where it's bridging onto another collector vessel. You can really see how a nice, slow, firm massage gets that dye moving. The MLD sequence that we select relates directly to the patient's most evidence-based drainage region. So where are we taking that fluid? For both upper and lower limb lymphedema, we've developed 2 massage sequences and we teach these in our certification courses. We have a simple sequence for both the arm and the leg that drains or directs fluid towards those original drainage regions. And this is the one we spend a lot of time on because this is where most of our patients, this is the sequence that we select for most of our patients. We also have developed a complex sequence that directs fluid towards those compensatory drainage regions. And so our cancer-related leg lymphedema patients, it's a bit of a spoiler alert for this afternoon's workshop, but we would select the complex sequence for our cancer-related leg patients, especially those that present with, if they're in a thigh-high garment. It's quite common to see patients in a thigh-high garment with, Louise calls it muffining. I don't know if that's a term in America, technical term, but they'll be swollen above the level of their thigh-high garment, almost like we're helping that fluid in that dermal backflow pattern get to the thigh, but we're not helping it all the way around to those drainage regions. And so we end up with a bit of a bottleneck. So moving on to compression. So understanding regions and patterns can assist our decision-making with regard to compression garment prescription in terms of fabric, compression class, and garment style. The fabric and compression class relates to the extent of dermal backflow. and the garment style is dependent on the location of the dermal backflow. So we ideally want to garment to a point that's proximal to the most proximal point of the dermal backflow. Sorry, that was a bit clunky, but I think you're with me. In terms of exercise, our anecdotal findings are that there's a strong correlation between the patient's activity level and the speed of fluid movement through the dermal capillaries. So when a person's very active, fluid appears to move more readily, more quickly through that dermal backflow, albeit with help from the therapist. This helps us to encourage our more sedentary patients when educating them on the importance of exercise and building muscle mass to help with their lymphedema. And Hiro is known for asking patients whether they are an elite athlete from seeing how quickly fluid moves through their lymphatics. Moving on to skincare. When discussing skincare, we can encourage our patients to apply their moisturiser in the likely direction of the lymphatic flow if we are understanding where they might be draining to. It also allows us an objective image of a slow and congested system. And so this helps in explaining the importance to our patients of maintaining the skin as a barrier, as they're able to see how easy it is for pathogens to hang around and proliferate in that high protein environment. Objective imaging of their own drainage is a really powerful education tool. And often when people begin to understand what's happening in their body, they start to connect with their treatment and they start to take ownership of their self-management. And I think this can be true of people that have ICG or people that don't have access to it. So understanding what's happening in your patient's body and being able to give them information on this research and say, we don't know for sure that this is where you're draining to, but between us, we want to be detectives and we want to work out where your most likely or your most evidence-based regions are so that we know where we're taking this fluid. Patients often reflect on how empowering it is to see their lymphatics and to fully understand their drainage issues. It can also help to guide some of our other modalities of treatment. For example, when prescribing the use of a compression pump, if they've got widespread dermal backflow in the limb, we're going to recommend slow speeds and relatively firm pressures. If we can see dermal backflow moving up and onto the abdomen, we might select a pump garment that includes the abdominal section so that we're helping that fluid all the way to the drainage region rather than just giving them a thigh high. So moving towards a conclusion, which we do need to do, ICG and the new evidence that it brings to the world of lymphedema is really exciting. This slide highlights the opportunity for the revision of some of the treatment principles that existed in this field before we had access to this new body of research. I think like any new research, it will take time for this to be disseminated, understood, digested and incorporated into routine clinical practice. But it's my hope that by sharing our work with you today, it will make you curious to learn more about how ICG is helping to shape this contemporary understanding of lymphatic compensation. That it might help you raise discussions about this research when you go back to your clinics. You might see fellow therapists directing fluid from an arm towards an inguinal region. They might be performing a light effleurage massage on their patients, or they might be avoiding an original lymph node region. So we don't want to say you're doing the wrong thing, but we might want to just introduce the fact that this research exists and that they might want to pull up a paper from the alert program to read about some of this. Please, if you have any questions, feel free to reach out to our team in Australia. We do encourage and we do love to talk about this research. So we'd encourage you to do so. So some of our take-home messages, I won't go through all of them. Some of the highlights that identifying that region and areas of congestion does allow us to personalise lymphedema management and care, whether your patient has access to ICG lymphography or not. That lymph node dissection surgery doesn't always block that original pathway. We won't go through these numbers of the leg, but We will be revising some of this in the workshop this afternoon, and we will have the opportunity to practice applying some of these strategies to a real life case study. One of the other ones I'd like to highlight there is that in the case of lymphedema, MLD should be slow and firm over areas of swelling. And that research is ongoing to explore longer-term outcomes of ICG-guided MLD and ICG-guided compression garment recommendations. And that our ICG lymphography findings have translated across our education, research and clinical programs to deliver holistic, personalised patient care and enhance the experiences of our students. Thank you.